ENT instruments by P L Dhingra. This section intends to introduce only the commonly used instruments in operative surgery and is by no means an exhaustive list. Other instruments used for routine diagnostic ENT examination are dealt with on page 443. Ear instruments. 1. Myringotom. It is a lancet type angled instrument used for myringotomy. Alternatively, a sickle knife used in myringoplasty can also be used to perform myringotomy. Mollison's mastoid retractor used in mastoidectomy to retract soft tissues after incision and elevation of flaps. It is self-retaining and hemostatic. Jensen's self-retaining mastoid retractor used in mastoidectomy similar to Mollison's retractor. Lampert's endoral retractor used for endoral approach to ear surgery. It has two lateral blades which retract the flaps and a third central blade with holes. The central blade retracts temporalis muscle. The central blade can be fixed to the body of the retractor by its holes. Lampert end oral speculum. It is like the Vienna model nasal speculum but curved. It is used to spread open the meatus while giving local injection or making an end oral incision. Mastoid gauge used to remove bone in mastoid surgery. It is available in various sizes. However, it is not used these days. A drill is preferred to gauges. Lampert's curette scope used for removal of bony septa and granulations in mastoid surgery. McKibben's curette and cell seeker used in mastoid surgery to explore the air cells with one end and to curette the intervening septa and granulations with the other. Farabiu's periosteal elevator used for elevation of periosteum from the mastoid cortex in mastoidectomy. Nose instruments. Lichwitz torcar and cannula used for proof puncture, antral lavage. Puncture is done in the inferior meatus as this site is easily accessible and safe. Rose's sinus douching cannula used in irrigation of maxillary sinus which already has a nasoantral window in the inferior meatus as after intranasal antrostomy or Caldwell Luke operation. Hook arrow outside indicates direction of the tip of cannula. Luke's forceps used in Caldwell Luke's operation, submucous resection operation to remove bone or cartilage, polypectomy to grasp and avulse polyps, and to take biopsy from the nose or throat. Nasal snare, crochet, used for removal of nasal polypi. Polyp is engaged in the wire loop and avulsed. Wire used is this snare is 30 SWG. With the advent of endoscopic surgery, it is no longer used. St. Clair Thompson's nasal speculum. It has long blades which are curved from inside, used in nasal surgery, example SMR operation or septoplasty. Killian's long bladed nasal speculum used in SMR or septoplasty operation to keep mucoperiosteal flaps away. Tilly's dressing forceps used for nasal packing, ear dressing, removal of foreign bodies from the nose. It has a box joint. Hartman's dressing forceps similar to Tilly's forceps with same uses. It has a screw joint. The jaw is serrated and grooved. Weil's dressing forceps used for packing the nasal cavity or ear canal. It has spring-on action. Belanger swivel knife used in removal of septal cartilage in SMR operation. The blade of knife revolves automatically and changes direction when cutting the cartilage anterior posteriorly downwards and posterior anteriorly. Different sizes of blades are also shown. It can be used to harvest septal cartilage as a graft for reconstruction. Killian's nasal gauge, bayonet shaped, used for removal of septal spurs or bony crests and ridges in SMR operation. Freya's double-ended elevator used for elevation of mucoperichondrium or mucoperiosteum in SMR or septoplasty operation. Walsham's forceps used for disimpacting and reducing fractures of nasal bone. Ash's septum forceps used for reducing fractures of nasal septum. Instruments used for microlaryngeal surgery. One is a laryngoscope, two is a chest support, three is the suction tip and other instruments, four is a fiber optic cord, five various types of microlaryngeal instruments, six is a specimen bottle. Esophagoscope, used for diagnostic or therapeutic esophagoscopy. Length of esophagoscope and its lumen vary with the age of the patient. Mechanism of illumination is similar to that of laryngoscope. Handle at the proximal end of the esophagoscope indicates the direction of the longer end of the bevel at the distal end. Illustrated here is Negus esophagoscope with twin proximal lighting. Bronchoscope similar to esophagoscope but has openings at distal end part of the tube which help in ventilation of contralateral lung or side bronchi. Its distal tip is also beveled to facilitate its passage between the cords. Size of bronchoscope will vary with the age of the patient. For indications and techniques of bronchoscope, see page 499. Size of bronchoscope for different age groups is given in table A1. Size of tracheostomy tube and bronchoscope according to age. Preterm to 1 month, 2.5 to 3 millimeter. Size of bronchoscope tube 2.5 millimeter. 1 to 6 months 3.5, 3. 6 to 18 months 4, 3.5. 18 months to 3 years 4.5, 4. 3 to 6 years 5, 4.5. 6 to 9 years 5.5, 5. 9 to 12 years 6, 6. 12 to 14 years 7, 6. Smallest flexible fiber optic bronchoscope is 2 mm diameter. It can be easily passed through endotracheal tube of 3 to 3.5 mm in diameter. Ventilation bronchoscope. Various sizes are available for infants, children, and adults. Proximal end of bronchoscope consists of the following. See figure above. For fiber optic cord A, prism light deflector where fiber optic cord is connected. B. Main portal of the tube through which instruments like section tube or forceps for biopsy or forceps for foreign body removal or a telescope can be passed for passage of instruments or rigid scope. C. For introducing flexible instruments like fine suction tube or flexible forceps or for jet ventilation. C. For passing flexible instruments. D. For connecting to any type of respirator for ventilation or assisted respiration. Any of the openings B, C, or D can be closed with a single plug. D. For connecting anesthesia apparatus and ventilation. Bronchoscope 3.5 millimeter into 20 centimeter, 4.0 millimeter into 30 centimeter, 5 millimeter into 30 centimeter, 6 millimeter into 30 centimeter. These are the various sizes of pediatric ventilation bronchoscope sizes and adult ventilation bronchoscope sizes. The length of the bronchoscopes is 8, 12, and 17 inches respectively from pediatric to adult size. Tracheostomy tubes for adults. Various types available: uncuffed and cuffed tubes, double cuffed tubes. Each cuff can be inflated alternatively to prevent pressure necrosis at one side. Fenestrated tube, single or multiple holes are situated at the upper curvature. The holes help in speech production or in weaning from tracheostomy. Fenestrated tube is used for children for decannulation. Adjustable phalange long tube. Extra length tracheostomy tubes are used when pretracheal tissues are thick or swollen or to bypass a growth of stenosis in trachea. Flange is in these cases is movable and fixed at a desirable place according to the thickness of tissues of the neck. Single lumen tube. There is no inner cannula. Double lumen tube. They have an inner cannula inside an outer cannula. It is easier to remove, clean, and replace the inner cannula, keeping outer cannula in place for breathing. Suction aid tracheostomy tubes. They have small tube endings above the cuff to suck out pharyngeal secretions and prevent their aspiration. Tracheostomy tube with speaking valve. A valve is fitted at the outer end of the tracheostomy tube. It allows ingress of air when breathing in but closes when breathing out. In the latter situation, air finds its way to vocal cords to produce sound. It is used in long term treatment of bilateral abductor palsy or laryngeal stenosis. Digital closure of tracheostomy tube to speak is thus avoided. Classification of tubes according to the material they are made of. A tracheostomy tube may be made of 1. Silver, an alloy of silver, copper, and phosphorus, example Fuller, Niggers, or Jackson's tube. PVC, polyvinyl chloride, they are disposable single use tubes and thermoliable and thus adjust to tracheal lumen. 3. Silicone. Bacteria and secretions do not adhere to the tube and there is minimal crusting. Siliconized PVC. It has the properties of both the PVC and silicone and it is thermoliable and adjusts to tracheal wall while silicone prevents crusting. Silastic. It is soft and non-irritating and minimizes crusting. Armored tubes. They are plastic tubes reinforced by spiral rings of stainless steel. They are not easily kinked. This is the inner tube and this is the outer tube. Fuller's tracheostomy tube. It consists of an outer tube and an inner tube, the latter being slightly longer. The outer tube is made of two blades which, when pressed together, can be easily introduced into the tracheostomy opening. Inner tube has a hole in the center so that the patient can still have a chance to breathe from larynx even when tube is blocked at the outer end. Jackson's tracheostomy tube. It has three parts: outer tube, inner tube, and an obturator. The outer tube is not split and inner tube can be fixed to the shield of the outer tube by a lock. The obturator helps to introduce of tube into the trachea. Cuffed tracheostomy tube. When cuff is inflated, it prevents aspiration of pharyngeal secretions into the trachea. It can also prevent air leak. It is used when there is danger of aspiration of pharyngeal secretions as in unconscious patients or when patient is put on a respirator. Cuff should be deflated every 2 hours for 5 minutes to prevent ischemia and damage to the trachea and cartilage necrosis. Nowadays, tubes with two cuffs are available, and inflation of the cuff can be alternated to avoid cuff pressure at one side of trachea. For inflating the cuff, for aspiration above the cuff. Cuffed suction air tracheostomy tube. It is likely like an ordinary cuffed tube but also has a suction tube which reaches above the cuff. It helps to suck out pharyngeal secretion collected above the cuff. Secretion should always be done. Suction should always be done before deflating the cuff so that accumulation of pharyngeal secretions do not get aspirated into the trachea. How to select size of endotracheal tube in a child. For size of tracheostomy tube in a child, see table A1, page 538. Size of tube internal diameter in millimeter equal to age divided by 4 plus 4. Length of the tube in centimeter, size of tube into 3. For example, in a 4-year-old child, size of the tube is 4 divided by 4 plus 4 equal to 5 millimeter. Length of the tube is 5 into 3, 15 centimeter. Roughly, size of the tube is size of the child's little finger. How to select size of tube in adults? Tracheostomy tube for adults is selected by size or number of the tube. Larger the size number, greater is the inner diameter. In adults, tubes of inner diameter varying between 6 to 9 or 10 millimeter are used. Sometimes size of the tube expressed in French gauge, which is 3.14 times the outer diameter of the tube. Fg equal to outer diameter into pi. 3.14 or approximately 3. For example, a tube of 36 Fg will have an outer diameter of nearly 12 millimeter. Size of Jackson's of Negus tube is usually indicated by Fg. For size of tracheostomy tube in infants and children, see table A1, page 538. Laryngeal mask airway. Laryngeal mask airway (LMA) is a device with a tube and a laryngeal mask which fits over supraglottic region. The tube has a standard 15 millimeter connector. They may be reusable after sterilization or single use. The latter are made of polyvinyl chloride. Size of mask is selected according to the weight of the patient. Sizes vary from 1 to 6. Size 1 for neonate, size 4 for average adult woman, size 5 for average adult man, and size 6 for large adult weighing more than 100 kg. In Indian population, slightly smaller size of the mask is used. The cuffed mask is first deflated and positioned over the larynx and later inflated. It is used where the face mask is ineffective and intubation of the larynx difficult. Other advantages of LMA include to intubate the patients with endotracheal tube less than 6 millimeter in diameter directly, or to first pass a stylet and then railroad endotracheal tube. To pass flexible bronchoscope for fiber optic assessment of airway and then pass the stylet. LMA is not as effective as endotracheal tube to prevent aspiration of gastric secretions. It is in its use is contraindicated in obstruction in areas of glottic and subglottic, and use cannot be used in patients with trismus. A is a somet microdebrider used in FES. It has a suction irrigation tube and blade. Various blades with debrider, straight for FES, 30-degree for maxillary sinus, 3 blade for adenoidectomy. Master drill. A is the motor, B is the curved handpiece, and C is a straight handpiece. D is the different types of burrs. Some common instruments used in FES from top to bottom. 1 is a probe, 2 is a sickle knife, 3 is a curved suction, 4 straight Beckesley forceps, 5 curved Beckesley, 6 retrograde cut through cut forceps, 7 curate straight, and 8 J shaped curate. B is the endoscopic fiber optic cord. Thank you.